presentation in the session, the Terminology Leading Practice stream of the SNOMED CT Expo 2022. And for those who don't know by now, because you've been in the room sitting there for a while, my name is Jane Miller, and I work in the collaboration and clinical engagement teams at SNOMED International, and I'm moderating this session as well. All questions will be answered at the conclusion of the presentation. And for those who are online, I will be keeping an eye out. Please put your questions in the Q&A box so that I can represent them for you in the room. And those on site, I will run around with the microphone, as I have just ably done, and I'm getting my points on my watch. So now, without further ado, I'd like to introduce Rob Hausam from Hausam Consulting, who will be presenting Enhancing Terminology in the International Patient Summary, Incorporation of the SNOMED CT IPS Terminology sub-ontology in brackets in the IPS specifications. Rob, carry on.
Thank you, Jane. It's really a pleasure to be able to be here and talk to you about the IPS terminology and the IPS specifications. And I think my biggest challenge will be to make sure I can master the clicker here, but and move these forward. And the other thing is it's going to be a challenge. It's a daunting task to follow after the excellent presentations this morning in the keynote, and then the excellent presentation we just had on this topic, and trying to avoid too much overlap and all that. But we'll see what we can do. I'm sure I have way too many slides, so I'll be covering going through the first part of it at least probably pretty quickly. But and I got to get the clicker to work. Okay. Anyway, so first is a little bit about what is the IPS. You've already seen some of this, and you might recognize a few slides as we go through here. But so, you know, the IPS is the International Patient Summary, as we've already heard. And international is emphasizing the need to provide generic solutions for global applications beyond any particular region or country. And when we talk about a patient summary, we're talking about a health record extract that's a standardized collection of clinical and contextual information, and it's basically a snapshot in time, and it's intended to support subsequent care scenarios for a patient. And this slide kind of summarizes the first 2 points again. It's a snapshot in time, the health record extract, it's international, and the scope is basically intended, the initial use case basically was unscheduled cross-border care. And we were thinking, I think originally we're talking about international borders. So I'm here in Portugal, and if I get sick or injured, or whatever, I may need the healthcare system. That's the kind of original scenario that we envisioned. But we very quickly wanted to make sure that we did not in any way limit to only that. And we the borders that we're talking about, across borders, really any kind of boundaries of sharing health data. So that might be, within a country, it might be regions, or, states in the US, whatever it might be. It might be, within a city, it might be different health systems. It could be at any level where there's barriers to sharing healthcare data. So that's what IPS is, the scope to be able to address. Okay. And this slide, if you can, hopefully can see it, basically just shows you a bit about what's contained in the IPS. And we have some required sections, which basically are our medications, allergies and intolerances, and clinical problems, the problem list. And then there's several recommended sections, and immunizations is sort of almost becoming our fourth required section. It's not officially that in the spec, but it's obviously become extremely important to be thinking about that over these past 2 or 3 years. And then of course you see the rest, histories, procedures and devices, and laboratory diagnostic results, and then the other optional sections, which are also included. And one principle, which doesn't necessarily show up on the slide, but is that we really are trying to be open in the standard and allow for all the relevant data. And so if there's something that doesn't really fit into one of these boxes, it's still potentially possible to include in an IPS. Okay. So these other slides basically talk a little more about where it makes it up, and you've kind of seen that. And if you note over on the right side, there's mentions the library of profiles, and there is a notion that you may not only and always be thinking of a document paradigm, but you might have uses, which you'll see in the next slide of, for actual individual profiles that may have more specialized uses. And so, with that library, you could take that and you could, you could record your vaccinations, and you could have, basically sort of the equivalent of the WHO yellow card. And if you go a little bit, farther with that, then you take the IPS and maybe some, again, during the pandemic, some, specialized tools and information, and you use that to create, you do something that you have a more specialized immunization IPS that's really focused only on that, and you can have a vaccination certificate in FHIR, and then ultimately you basically transform that and can become a digital certificate. So those are some, we're trying to accommodate a whole spectrum of potential uses, but still kind of retaining that fundamental focus on a document that summarizes the relevant information that's needed for a subsequent clinical encounter. All right, so now I'll move on and talk a bit about the actual IPS project itself. And this slide kind of is a nice summary, and it's pictorial of kind of how we've worked together amongst multiple standard development organizations in order to, to get to where we are with this. And, you see the ones listed, ISO at the top, which provides basically the data standard that talks about the content that we're including, but doesn't really talk about the structures or anything like that. And then the SEN work, led to this. You'll see the next picture, which you've seen before, will kind of show how these all fit together. But HL7 sort of being the primary standards developer, and then IHE taking that and basically profiling it for testing and conformance and being doing the things that they're really good at doing. And then SNOMED, of course, on the terminology side. And we all, you could analyze that picture and see all the different roles, but it's a nice diagram that I think kind of shows what we're about and the way we're working together. And so here you just saw that slide just a few minutes ago, the same. And again, we won't go through into the details, but you see that we've got the HL7 and the red box is the IPS, the CDA implementation guide, which we do have, and the FHIR, IG, which FHIR is getting most of the focus right now, and it is the primary focus in HL7 for most things. But the CDA is still, with us and will be for quite some time, and we're still committed to trying to keep that moving forward as best we can, and then aligned with what we're doing in FHIR. And we've got, of course, SNOMED, it was already mentioned, and ISO at the top, forming, what's the content, and then these other things around the sides. So that's kind of, again, picture of how we work together on this. All right, so now I'll talk a little more about the terminology considerations within IPS. And when we were looking at this, we had kind of a few characteristics that we wanted to try to achieve, and obviously has terminology that's available. And the reason that's up there top basically is we looked at some things like for medications, we were looking at what IDMP, but we really found, certainly at the time that we were starting to work a few years ago, it's a model, but it's not, the content's not really there. So so we need something that's actually available and usable, and it needs to be it's fit for purpose, obviously, and acceptable for use globally. And there's some different aspects to that we'll talk about a little further, but has to have some intent of global use, and with some significant global participation in its development and maintenance and all of that. And so key principle you could say is we make the IPS value sets available for global use at no cost for implementers of the IPS. Now, of course, that no cost is a significant thing to say, and we'll talk about that a little bit more too. But so when we take this terminology principles and we try to put them into HL7 FHIR and into the FHIR IPS implementation guide, we're looking at, we have what I'm terming a base terminology binding with the element in the FHIR resource. We have there's a single binding to a value set, and that's the way HL7 does terminology. It takes an element and it binds it to a value set, it never binds directly to, say, a code system. Like, it doesn't go directly to SNOMED CT. There's a value set, which is, like a SNOMED, very similar to a SNOMED reference set. And it is a collection of codes that are suitable for use in a particular context. And that context is the key there. And so we provide a base binding, which is a preferred binding strength, as it's highlighted there. And then, and what we're doing in our new update is we've tried some different ways to show how we might have multiple choices in bindings. And there's a new capability in FHIR now that, with additional bindings that could be specified, and something that Graham Grieve has recently added to the specification. And we're trying to take advantage of that to present other choices of bindings. So let's see. I'll just go ahead and, you can read through that, but the way that looks in one example, this is immunization resource in FHIR, and you see in those yellow boxes, basically you see binding and then additional bindings, and that's the way it looks now in the specification. And so you see that, there's what they call a max binding in all languages. This is not really what we're talking about here, but we have, for the actual vaccine code, we have the preferred binding to vaccines, which is a binding to a SNOMED-based, SNOMED-based value set, and then additional bindings, which are basically choices, and one to another value set that's based on particularly the IPS free set. And when we fully implement this, that's kind of going to go away because, what Alejandro we were talking about before, and I'll hopefully, if I have time, we'll talk about some more of that in a moment. But we also include one for, the WHO ATC, and we also have some HL7 codes for absent and unknown. So, and those are now able to be presented that way. So next couple of slides just talk about some choices that have been made and what's currently there. SNOMED is, we tend to use, we basically say it's the primary terminology that we try to use whenever we can. And so these all have that. Some of them also for allergies, medications, and immunizations also have the ATC problems that doesn't actually have anything else. But in other areas, it's a little bit different. In laboratory pathology and imaging, then you can specify LOINC. Interesting as of today that in the future that will be maybe something a little different, but we'll see how that kind of plays out in our specification. But laboratory results are SNOMED, including microorganisms, and we have some other choices that were made in other areas, like answer codes for smoking status, and and medication dose form and route. We chose the EDQM from Europe. Those all, we might revisit those in the future, but right now that's where we are. So, absent and unknown data I mentioned earlier, and choice there was made to not use SNOMED, and I'll say a little bit more about that in a subsequent slide here. But so now we'll talk a little more detail about SNOMED in the IPS. There. So we consider, SNOMED clearly the premier global clinical terminology. It's an obvious choice to use in IPS. It's got the broadest coverage, and the community, all these things that you all know. That's why you're here. But it's for the most part, it seems to be nearly an ideal choice, for using an IPS. But there are some limitations with that, and to make it, an IPS value set, for based on SNOMED CT that's available for global use at no cost isn't quite something that we can do, because of membership model and all that. And I won't go through the details of that. I think you all know what that's about. But the 43 member countries that we've talked about, it keeps growing, and that's a great thing. But it's certainly not all countries in the world, and not all regions as well represented as others. So that does present a bit of a challenge for how to manage that. And so anyway, that just is a little bit more about that. Let's see what else to highlight. So we just basically, it's a barrier, and we need to have a solution to deal with that. And so, and there's one more another thing just to mention about limitations would be that there's definitely content that's not actually yet in SNOMED, or maybe won't ever be added. And that's where it gets back to that absent and unknown data that I mentioned. We looked at that, and the needs in IPS were slightly weren't quite completely aligned with what was in SNOMED, and we made a request to add some content on the no information codes, and that was not accepted. It's just a few years ago that we did this, but and what we have for the no known codes that are very similar, but they don't. In the IPS, we have an additional notion of, we're talking about no known information that is relevant for the purpose of the summary. It's not necessarily that there is no information out there that you know, but it's something that that would not be included in the summary. So it's a slight different nuance and meaning. And so we have chosen to stick with the HL7 codes with that for now. But I think it's something we might want to revisit, as we go forward. All right, so the solution that we originally came up was the free set, and then the subsequent incorporation of the free set for IPS and all the other free sets into the GPS, the global patient set. And that's what we have currently in the published version of the IPS standard. We have value sets based on GPS, for that purpose. But now, moving a little further, we have obviously the new kid on the block, basically the IPS terminology, which was a very welcome thing to see coming from SNOMED International. And we're just now looking at how can we incorporate this into our specifications and make the best use of it, and trying to work through the details of that. So, all right. So I took these from the IPS terminology user guide for the beta release version, and we will read through all of that. But basically, it's evolution of the preset and providing advanced features, just like all the things that you've already heard. So I won't repeat the excellent presentation before, but we have the hierarchy now, and it's a true sub-ontology, and it's a free resource available particularly for the non-member use. So this slide just has some more links to the various places to get the documentation, which might be useful to you. And the beta release, I think, became available in May this year. The official release is now, as I understand it anyway, and I could be corrected if that change I don't think it's changed since yesterday, but anyway, November 30th is what was expected, and then there should be yearly updates after that. And and then the prior presentation covered a lot of other details. So, all right, so I know I'm speaking rather quickly, and I don't know how much time we have, so you'll have to keep me reined in probably. But so how do we incorporate this into actually into our HL7 FHIR implementation guide? So what we are trying to do, basically, the key goal is to have, as Alejandro did already mention, a single value set definition expression should be able to be used, regardless of which SNOMED edition or the IPS terminology that you have available to you. So if you're a SNOMED member, then you have, obviously the international edition available. You may have your own national edition also, which could potentially give you even more content, as he demonstrated. But if you're in a SNOMED non-affiliate and you only have access to the IPS terminology, then you can still use that value set definition and expand that value set on a FHIR server shown and get the content that you would have access to. And so that's the goal is to make that to make that work in our specifications, and we're still working through exactly how that all should be done. But so this is about benefits, and it can being able to incorporate this in the specifications, we think can serve as a starting point for implementers of IPS. It does provide a real value, even if it's a limited value, from being able to use SNOMED CT and all the capabilities it has. And I think it's an opportunity for organizations and individuals in non-member regions to be able to experiment with IPS. With SNOMED CT and be gain familiarity, and it may lead to further adoption of SNOMED CT in various areas. And so hopefully it's a win-win kind of thing. And we expect to continue to working on this together and trying to further enhance capabilities and make it even better and more comprehensive as we move along. So get into a few more details here. This slide basically just shows, some places, some value sets, not all of them, but many where we've incorporated content. And we have a exception, medications, which has only a very limited amount now. Medications has been a problem area for fighting, and we've got, let's see. All right, so how much time do I have, James?
No, if there's anything essential you want to do, cover it. But yeah.
Anyway, what I'm showing here is, how some value set definitions look in FHIR, and we've got some things that are in there right now that we've crossed out, and we plan to remove the the version elements, which kind of are limited. In the FHIR version, that basically is how you specify the SNOMED edition, and we're going to remove that so we can actually have that one definition that works in all cases. We'll do that, and this shows, we also have a reference in some of them to the actual IPS ref set, and we'll also be removing that, again, make it as flexible as possible and have only the need for one. And let's see. Anyway, the timelines about this, we're hoping to publish this very soon. And I'm going to skip over this, but there's some issues, with challenges and solutions we're trying to work through, like, it's snapshot release, there's no history. We've got, some URI issues to look at. Let's see. And so I kind of had this, this is a proposal for how we would end up with the value set definition. I already kind of talked about most of that, but future plans, we'll get to the last part. And we've done this work so far in the FHIR implementation guide that I've been talking about. And once we get that done, whatever timeline we end up with exactly, we'll also pay attention to the CDA version and try to keep those in sync as much as possible. It's kind of maybe resource constrained potentially, but that's our intention. And so we will, and we'll also, those updates will spill into the other standards, including the IHE profiles and all of that. So let's see what else I have here.
Okay.
Yeah. And
there we are.
I have a few more. That's the last slide, but anyway, so we're going to try to, we'll get these updates out there as soon as possible, and then make it available to the community, and we'll carry on forward.
Okay, thank you. Rob will now take questions, and I'll run around with the mic. Oh, we've got one straight away. I can't even get out the chair.
You can ask a hard one, Peter.
Yes, might it be worth us retaining the ECL expression, which includes the IPS identifier, ref set identifier in the specification, even if we're not going to use it in the binding? So I can see why you don't want to use it in the binding, obviously, because it's got to work in member and non-member countries.
Yeah,
but I think it should be there. Perhaps.
Okay. Yeah. Well, maybe we can kind of talk about what's the best place and way to do that. But I wouldn't disagree. My point was strictly really about it being in the binding. Yeah. Mm-hmm. Yeah.
Do we have any other questions?
You've heard enough about IPS.
Oh, have you got another one, Peter?
No.
No, I don't have any at the moment. If you want one.
Only one thing, but when are we going to be ready? When are we going to publish?
Well. Okay. Well,
Line that was, when are we going to publish it?
yeah, that's interesting discussion. I think one of the things that actually it's sort of late changing with this, what's happening this week, and we were talking yesterday about whether we need to try to align the publication so we could actually, in the specification, take advantage of the full IPS terminology release and be able to officially include that. But that pushes our publication deadline, timeline down to November 30th, so we could be in sync. And I thought that might be a reasonable compromise. I talked with one of my colleagues subsequent to that conversation, and he's not so sure that's a good idea, because there's a lot of pressure to get this, our updated version out the door as soon as possible for people in implementers in Canada and other places. And so I think another thing that we may consider is going ahead and publishing as rapidly as possible, and then going almost immediately to an HL7 ballot with further updated material and getting further eyes on it through the ballot process. And we're still in the window where we could actually do that for January. So, that's just my really off the cuff idea just as of a few hours ago, but we'll see. But anyway, it'll be published. The new update will be soon, and then either October or at the latest in November. So.
Any more questions? Oh.
Yeah, you mentioned that the medicines was a problematic area. Can you give us some thoughts on what the problems were?
I can give you some thoughts. I don't know if I can give you any answers, but maybe partly. But so, the problem with it basically is that medications, particularly prescribable ones that a patient's actually going to be taking are all so localized, so nationally based. Everyone has their own terminology. We've got ARC-SNORM in the US and DM&D in the UK, and I don't know of all of the other ones that are out there, but there's a lot of them, and they're really is not the same. So you can't just pick one. And then looking for something that's global that covers the space, you end up with more classification oriented things like ATC potentially, or the future IDMP and whatever it's substance and product codes will be and could be used. And we might need to revisit that one. We kind of passed that by a few years ago. But anyway, it's not the clear obvious solution, except for SNOMED would still be, an ideal choice. But the real problem is then how do you decide what's a small subset of medications that I can include in the free set? What are the important medications? Sometimes I think the most important medications are the ones that are the rarest used, and so if you only go by frequency of use, you probably don't get the right set. So there's no obvious way to decide that. However, and one of the slides here, which I actually passed over so you couldn't even see it, but there has been an agreement to include the WHO list of essential medications in the IPS terminology. And I think that's at least a significant step forward. And I also noted, because I wasn't even aware of this, that there's also a list of essential medications for children that they have available. And that hasn't been mentioned, but I'm going to ask if that maybe could also be included. So that's one part of the answer.
Anything else? Okay, then I'm going to close this session. Thank you again, Rob.